Atypical meniscus tear is basically which are rarely seen or which are relatively not described as of now. So the first lesion is a zip lesion. So zip lesion is nothing, it's a kind of a similar to the ramp lesion on the medial side. This is a zip lesion on the lateral side. And we have been seeing zip lesions so frequently that we developed this classification is already under publication and accepted just 2 days back. We classified into type 1AB, 2AB, 3, and type 4 and type 5. So these are certain subtypes of the zip. I will just show one of the complex zip type 3A, which is a complete tear of the meniscocapsular junction equivalent to the ramp lesion on the medial side. So this kind of tear are usually not visible. You have to go into the intromedial portal between the ACL and the femoral condyle, and like you do a needle test on the ramp, you have to do a needle test on the lateral side. You can see whole of the popliteus tendon is visible. So it's a huge lesion which is not visible from the front. It will be visible only from the back once you are into the posterolateral compartment. And such kind of tear, I use a passport cannula and use a simple suture lasso technique in which you pass ethylone first onto the capsular side, followed by onto the meniscus side, and just relay with the fiber wires. So if one stitch is not sufficient, you will go ahead and put one more stitch. So this is how you repair the type 3. Rest of the type 1 to type 4, how to repair that's a different case scenario, which we will maybe in some other time we'll discuss. So if you see the typical root tear by LaParade has given the classification type 1 to type 5. So this were incomplete tear. Type 2 was a tear which was within 1 centimeter. So in practice, we were seeing almost type 2A, 2B, 2C, 3, 4, 5, everything we were seeing. And we started seeing more kind of root tear, and we extended the classification by LaParade into type 6, type 7, and type 8, which is already published, and it has been recognized by LaParade as well. So this is a type 6 tear in which there is a root tear along with the horizontal cleavage tear, which was not described by LaParade originally. This is a type 7 tear, which is a combination of root as well as ramp. You can see all of the meniscocapsular separation is there, and there is a root tear. And type 8 we have described is a complete loss of the root extending more than 1 centimeter. So these are the 3 challenges which you see in the root tear. So how to do a repair of type 6, type 7, and type 8 LaParade. Type 6, we do a horizontal cleavage closure, and we use a suture anchor to do our repair for type 6. Type 7, we do a double row technique. It's a double row anchor technique, which is published in Journal of Isacos, accepted already. So you use a suture anchor for the lateral row, and for the medial row, you use a tunnel, and you take whole of the bite, and you can see whole of the root along with the ramp is getting reduced. So this is type 7. The type 8 is relatively challenging, so we are doing a root reconstruction using a gracilis graft. So we use make the 2 tunnels. We take the gracilis graft and tie it along with the remnant of the meniscus. Still, we need a good follow-up for type 8. So another rare type is a high horizontal cleavage tear along with the ramp tear. So you can see I'm looking from the high posteromedial portal, and this thing is coming from the low posteromedial portal. You can see a horizontal cleavage along with the ramp tear. So this kind of tear you can repair. You can take whole of the horizontal cleavage using a scorpion, both the inferior and the superior bite, and then you can take a bite onto the capsular side, and then you can do simple repair. So still I'm looking from the high posteromedial portal and from the low posteromedial portal. It's a simple technique. Again, this is a pass, park, and tie technique. So you keep on parking the suture onto the anterolateral portal and keep on tying the next set of sutures. Another rare kind of a situation is a T-shaped tear along with the lateral meniscus complex tear. You can see this is not only the radial tear of the lateral meniscus going up to the capsule. This kind of a tear we use again a suture anchor. So with the suture anchor, you will first do a radial repair by using a side-to-side suture, and then you will use a all-inside device to do such kind of a repair. So this is a suture anchor technique in combination with the all-inside technique for the meniscocapsular junction. So this is again one of the rare type of the tear, which you have to use a combination of techniques. So this is how you can see the radial we have done, but still meniscocapsular junction is torn. So now we will use this device, and then we will do a fixation of the meniscocapsular junction. We've got a situation in which there is a lateral meniscus tear, but there is a substance loss. You can see there is a substance loss of around 1 centimeter. Again, we have been doing this kind of cases, particularly for the young patient. We are using a gracilis as an interpositional graft. I am taking a bite first through the popliteus. So I am stabilizing my free end of the lateral meniscus with the popliteus. Once this is done, I will use a gracilis graft and I will pass my gracilis graft in such a way to interposition this gracilis graft, probably is going to come soon. So this is first time stabilizing a lateral meniscus along with the popliteus tendon. So once this is done, the next step would be putting a gracilis graft. So this is how you tie the gracilis graft and suture the gracilis graft to the remaining of the meniscus. Still, we need a good long-term follow-up to judge what is going to happen with this kind of surgeries. We got some cases in which we have seen the root tear of both lateral meniscus as well as medial meniscus. And we got 5 cases in which we were having a torn medial meniscus root as well as lateral meniscus root. Again, we prefer to use an anchor onto the medial side as well as onto the lateral side. So this is the medial meniscus root repair, which is followed by, you can see this is a lateral root also torn. So we're doing a repair of the lateral meniscus root as well using the suture anchors. So root avulsion, again, it's a type 5 which has been described by LaPerrette, but you can see we have seen this kind of a root avulsion, which is a bony avulsion. And again, a pull-out suture technique would be best for such kind of a suture. We will make a transtibial tunnel, and then we will use a scorpion to pass the fiber wire. And then once you reduce, you can see it's like a ACL avulsion. Whole of the root along with the bony fragment is going to reduce at its original place. One of the rare cases is a young boy, 16 age. He's got a triple bucket tear. So you can see this is the first bucket, this is the second bucket, and once you go back, you can see there is a meniscocapsular tear, that is a ramp also this patient was having. So if you go for a meniscectomy, in such case, nothing will be left at the age of 16. See, whole of the meniscocapsular junction is gone. So whole of the tibia is still exposed. So this is a triple bucket tear. You can see the 3 buckets. So what I have done, I have gone from the high posteromedial portal and from the low posteromedial portal. First, I have addressed the second bucket along with the capsule. I passed the 4 sutures from the back. So once this was done, you can see the meniscocapsular junction was stable. And once I was in, you can see the meniscus was looking relatively good. Then I have gone ahead and then I have done the inside-out repair for this patient. So 16-year-old male. So this is how a meniscus can still be preserved by using a combination of inside-out and the posteromedial technique. The terrible trial of meniscus is a new thing which has been described recently by the LaPerrette himself as a new terrible triad, but we have seen around 5 cases of terrible triad. I was not knowing, otherwise I would have named it as a terrible triad. It's a basically ramp tear with a lateral meniscus root tear along with the ACL. So this patient, you can see he was having a ramp. So you need to address the ramp. As well as this patient was having a lateral meniscus root tear, again the LaPerrette's type 4, so oblique tear extending into the root. So you have to go ahead and do a ramp repair, you have to do a lateral meniscus root repair, and then you have to do ACL reconstruction. So this was done using a 2-portal technique. The ramp was repaired, and then the lateral meniscus root was also repaired using a suture anchor. So this is again an atypical terrible triad of the meniscus. Thank you.